Great. Thank you so much for that really kind introduction, and a huge thank you to the board and members who invited me here to speak. I'm really thrilled to be here to talk about my favorite topic, CLL. And I come from the west, from Vancouver, and I realized when I was looking at these slides this morning, I should have put a picture of the beautiful Niagara Falls. I hope you've all had a chance to go walk around. Yesterday was incredible, so I think we're all very lucky to be here today. Here are my disclosures. I have received research funding and participated in advisory boards and received honoraria from the companies listed here. So I'm going to start with a case. This is a fictional case, but a fairly typical case that I see in my practice. So this is a 67-year-old man who's a runner. He actually runs long races, 5K, 10K, had some knee pain, or often it's just some unrelated reason that someone ends up doing a complete blood count, a CBC, and next thing you know, he's told he has leukemia. So we can understand through our patients that this is obviously a devastating situation. It's a shock, a lot of anxiety, a lot of questions come with this. And often the first question is, okay, well, how are we going to treat this? What are we going to do? So when we think about treatment for CLL, and as Dr. Ferrioli indicated, we often say CLL/SLL, and I just want to comment that when I'm talking here today, everything I talk about CLL treatment also refers to SLL. We treat and manage them both the same, essentially. So our main goals for therapy are two things. One is to prolong life, prolong survival, and then also, though, to improve that quality of life so that you can live well while being alive. As of today, CLL is incurable, but there's a lot of progress, and maybe one day that won't be the case. We've heard already that studies have shown that early treatment does not prolong survival and may actually worsen quality of life due to side effects. In addition, when you're on treatment, you can develop resistance to treatment, similar to when you think about antimicrobial or antibiotic resistance. The more you're on antibiotics, the higher chance that the virus or bacteria is going to develop resistance and grow through that. It's the same with CLL. The longer you're on treatment, the cells can start to mutate and develop mutations that cause them to be resistant to the drugs. And so as of today still, even though there's a lot of trials ongoing looking at this question, but as of today, all of our guidelines recommend watch and wait, or what we call active surveillance. And it doesn't mean that we're doing nothing. We do things during that period. We follow patients and ensure that a lot of their other health needs are being addressed. But for now, we do still recommend active surveillance when patients don't have any symptoms. So when do we actually start giving drug treatment? And you've already heard about this. So this actually comes from guidelines that were in 2018, or initially published. They've been updated over the years, but really it has not changed. These are still the specific things that physicians look for that are highlighted in these guidelines that were developed by the International Workshop for CLL on when we think about treatment. So I'll just read, we already heard these, but the main ones are worsening of your other blood counts, so your hemoglobin, which is your red blood cell count, if it goes below 100, your platelets, which are what help your blood clot, if those go below 100. We use this term massive or enlarging spleen, and we have a number to quantify this. If it's 6 centimeters below the ribs, that's when we consider that large, or if it's causing symptoms. Same with lymph nodes, if they get up to 10 centimeters, or if they're just starting to cause discomfort, they're rapidly enlarging, that's a good reason to start treatment. We talked about this rapid lymphocyte doubling time. This is how quickly the lymphocyte count doubles. Usually you need it to start at a highish number above 30, then we start to look at that doubling time. Often when that starts to happen, when the lymphocyte count, say, goes from 50 to 100 within 6 months, other things are also happening. It's not usually the only reason we start treatment. Usually at that point, you start to see some of these other symptoms. And then this kind of category we call disease-related symptoms. And the important thing here is a lot of people might have some of these symptoms, but it has to be that it's not related to something else, that you've really looked to make sure there's no other cause for these symptoms. So unintentional weight loss over 6 months, can't do your usual work or usual activities due to fatigue, fevers for 2 or more weeks without infection, night sweats, which are pretty significant, so we often use the term drenching night sweats for more than a month without infection. And then a couple of more rare reasons to start treatment. We heard about autoimmune complications that aren't responding to standard treatments, which is usually with steroids. And then disease sometimes involves other organs, kidneys, lungs, and that might be a reason that we need to start treatment. Okay, so let's go back to our case. So our patient, he was on active surveillance for 3 years, so he's now 70 years old. During that time, he made sure he was up to date on all his vaccines. We've talked about this: COVID, yearly flu shot, shingles, pneumonia, RSV as a new vaccine available. It's really important to make sure patients have regular cancer screening based on their age and sex. So for him, prostate, colon, skin cancer screening. He continued exercising, tried to have a balanced diet, got a lot of support through the patient community and family. But now he's beginning to feel more fatigued. He can only run about 20 minutes, whereas before he was running an hour. His lymph nodes are growing in the neck, starting to become uncomfortable, and his blood counts are going down. So the hemoglobin's 105, so a bit borderline there, and platelets are less than 100 now. His lymphocytes are 110. They're not rapidly doubling, but they're at that. It's kind of makes sense with everything else that's happening here. So at this point, he meets criteria, what we call the IWCLL criteria for treatment. So what are we going to treat him with? There are so many treatment options now for CLL. It really is an exciting time. And you'll probably hear me say this over and over. But I'm going to divide up them, and these are the main categories that we think about. So chemotherapy, monoclonal antibodies, we'll talk about those. Now what we call targeted therapy, immunotherapy, which is a broad category. I'm not going to talk too much about that. Cellular therapy, and the main one there is CAR T-cell therapy, and I'm not going to talk about that. I will likely hear about that from Dr. Alina in our future kind of what's coming down the pipeline. And then we rarely use surgery or radiation treatment. Those types of modalities are used a lot for other cancers. Sometimes for SLL, we might use a bit of radiation, or if someone has a really big lymph node that's particularly bothersome, it could be useful, but it's rarely used in CLL, SLL. So I'm going to start with chemotherapy. So chemotherapy are strong drugs which really kill any fast-growing cells in the body. So they kill cancer cells, which is great. That's what we want. But unfortunately, they also kill other fast-growing cells like hair, mucosal membranes, so they can cause mouth sores. They can cause indigestion, burning pain in the esophagus. They can cause diarrhea in the bowels. They can kill ovary and sperm cells, so lead to infertility. That's important in our younger patients. And can also kill normal blood cells, hemoglobin and platelets. Chemo's usually given through an IV, although there are some forms of chemotherapy. And the whole point is that it goes through the entire bloodstream. And that's really important in CLL because we know that the disease is all over. It's all through the blood. So the standard chemotherapy that we use in CLL is fludarabine, cyclophosphamide, bendamustine, and chlorambucil. And many of you, if you've been treated, likely have received those drugs because it's only been recently that these newer agents have been available. So we've used a lot of chemotherapy for CLL over the years. And it can be used alone or we use them in combinations. So monoclonal antibodies, this is kind of considered a type of immunotherapy because it is sort of mimicking what the immune system does. So as you heard, CLL cells are a type of B cell, which is part of our immune system. And they have a little protein on the surface called CD20. Antibodies are usually things our bodies make in response to bacteria or viruses. We think of them like a Y, and they kind of glom on to a bacteria or virus and then clear it from the system. But in this case, they actually engineered antibodies to glom on instead to that protein, to that CD20 on the B cells and clear it from the system. And these have been extremely effective in all sorts of lymphomas, but particularly CLL. The main ones we used was initially rituximab, and now there's kind of think of it as the new and improved version of rituximab. It's called obinutuzumab. So the pluses of monoclonal antibodies is that we do know from many clinical trials and studies that they prolong survival when we add it to standard chemotherapy. And even when we add it to the new drugs, it can deepen responses, meaning it can actually lead to clearance of more of the CLL cells in the body than without having it. Some of the downsides of these monoclonal antibodies are when they go in, they can cause what we call an infusion reaction. It's sort of like an allergic reaction. The body reacts, people can get fevers, their blood pressure can go up or down, they can get rashes. So it sometimes can cause this reaction when it's going in. It does cause more immunosuppression because if you think about it, this is an antibody to our B cells. So yes, it kills your CLL B cells, but it also kills your normal B cells, which are a normal part of your immune system that we all need to fight infection. So this is part of what causes immunosuppression in CLL patients. And it decreases people's ability to respond to vaccines because we actually need our normal B cells to respond to vaccines that we get. So it can cause more immunosuppression in these monoclonal antibodies. We often use this term chemoimmunotherapy. So I just want to mention that what this stands for is chemotherapy, so those IV drugs that we talked about, generally IV, plus a monoclonal antibody. And so examples of this are some of the regimens we do still use, but less and less now, but that we've definitely frequently used previously. Fludarabine, cyclophosphamide, and rituximab, we call that FCR. Bendamustine and rituximab, BR, and then chlorambucil with obinutuzumab. So we often use O or OBIN as our abbreviation for obinutuzumab. Okay, now I'm going to really focus on the targeted new drugs. So the whole point of targeted drugs is that unlike chemotherapy, which kills any rapidly dividing cell in the body, targeted drugs are specific to kill cells with certain targets, certain proteins on them generally, or proteins in them. And the main ones that are being targeted are something called BTK, it's called Bruton's tyrosine kinase, something called BCL2, and then there was a drug that we're not using as much anymore that was targeting a protein called PI3 kinase, that's the idelalisib towards the bottom. And then we have even newer versions of these drugs now. So we're gonna talk about all of these drugs. A lot of these proteins, so BTK, BCL2, PI3K, they're all within the cells and they're what help the cell actually divide and proliferate. So by blocking that or targeting those proteins, we can stop the cells from proliferating and cause them to die. And that's the whole point of these targeted treatments. So we have now we have a number of different types of Bruton's tyrosine kinase inhibitors. We call them BTKs or BTKIs. And the first generation, the first one that came out was ibrutinib. And this completely changed the whole landscape of treatment for CLL for the better. It really was remarkable when this drug came out. And what this drug does is it targets this protein called BTK. And this is a kind of a map of showing all the different kinases, which again are proteins that help cells divide and grow, showing all the different kinases in the cell. And BTK is that one that I've pointed to there with an arrow, but ibrutinib actually blocks all those red spots. So you can see that it's blocking BTK, which is important for B cells, but it's also blocking all different types of proteins. And this is in part what leads to a lot of its side effects, is the blocking of all these other proteins in the body. And we actually saw some unique side effects with ibrutinib that are kind of different than what we see with chemotherapy. So we see bleeding and bruising. Almost everybody on ibrutinib will have some kind of bruising, even if you don't bang yourself. We see that it can cause high blood pressure and some heart problems, including heart arrhythmias, particularly something called atrial fibrillation, where the heart really starts fluttering. And it can cause GI, which is gastrointestinal, so abdominal cramps, diarrhea, and then some skin and nail changes, some joint pains, some muscle aches, and that's all because it's targeting these other things, it's not just targeting BTK. So then came along what we call the second generation BTK inhibitors, and the two main ones right now that will talk about are called acalabrutinib and zanubrutinib. And you can see right away that they also target BTK, where the arrow is, but they target a bit less, there's a little less red on their circles there. So they actually have a different side effect profile, and in general, they cause less of these side effects than ibrutinib. Unfortunately, the bleeding and bruising seems to be about the same as with ibrutinib, but a lot of the cardiac side effects, high blood pressure, and then a lot of those GI, skin, joint, muscle pains are a lot less with these second-generation BTK inhibitors. Okay, I'm going to shift gears to a different type of drug called a BCL2 inhibitor, and the main one we use here is venetoclax. And the problem with venetoclax is actually, it's a good thing. It works so well that it kills cells very rapidly. So if you think venetoclax, very rapid cell killing. And what happens when this happens is that we have a risk of something called tumor lysis syndrome. This is where when the cells die, when they're all dying rapidly in the body, they release their contents into the blood. And these contents include things like uric acid, phosphorus, calcium, potassium. And these electrolytes can have effects on the heart and the kidneys. And so if somebody gets tumor lysis syndrome, they can have damage to their heart and kidneys. So with venetoclax, we've actually had to be very careful when we give it. We give people lots of fluids to help clear out all these electrolytes. We give them medication to decrease the uric acid levels. So allopurinol is a common one. It's actually used to treat gout. Gout is a problem of high uric acid in the body. And then we have another drug called respiricase. And then we do this really annoying thing with venetoclax, which is called a ramp up. So if any of you have been started on venetoclax, you know that this is annoying. Basically, every week you start at a low dose, and then every week you have to go up on the dose. It takes 5 weeks. And the problem is every time you go up on the dose, you have to have a bunch of blood work. Because every time we need to check your calcium, your phosphorus, your uric acid to make sure that you're not developing tumor lysis syndrome. And sometimes we even have to bring people into hospital to check their blood more frequently and give intravenous fluids to make sure that they don't get tumor lysis syndrome. But I have to say, and I always say this to my patients, it's a little bit of it's short-term pain for long-term gain. Yes, these 5 weeks, it's involved and intensive and annoying with all the blood work that you have to do. But once you get up to that full dose, in general, people tolerate venetoclax very well, and it's very smooth sailing after that. So it's really just this initial 5-week period. And if we do this properly and do it this way, we really do not see tumor lysis syndrome. So there's a lot of talk about tumor lysis syndrome, but in the end, we don't see it if we do it properly like this. So I really just want to highlight that thinking now of these drugs, this changing landscape of CLL treatment. So we started with, chemotherapy and then chemoimmunotherapy with regimens like FCR. In British Columbia, we use a lot of FR, which is just fludarabine rituximab, bendamustine rituximab, chlorambucil obinutuzumab. Now we're in this era of targeted agents. We've talked about ibrutinib. We're not really using idelalisib anymore. It has a lot of side effects. It's kind of fallen out of favor. Venetoclax, acalabrutinib, zanubrutinib. And now we're moving into this era of combinations of these drugs and what we call time-limited therapy, and I'll talk about that. But now we're getting into combining 2 drugs together, combining 2 of these targeted drugs together, like ibrutinib and venetoclax. We call those doublets. Or even combining 3 of them together, like acalabrutinib, venetoclax with obinutuzumab. Those are called triplets. So with all these options, how do we know what the best therapy for someone is? Well, we think about a lot of things. We think about clinical trial results. What have the studies actually shown? And we look at how well does it work? How do they work compared to one another? But also at safety. What are the side effect profiles? Which one is easier to take than another? We look at a patient's particular prognostic markers. We already heard about that from Dr. Ferrajoli. Particularly looking for deletion 17p by FISH, which is one of our what we call high-risk markers. We talk about a patient's fitness, and that doesn't really mean how much you can lift at the gym. It just means overall ability. Are you ambulatory? Can you walk? How far can you walk? Do you do exercise? If so, what kind? Getting a sense of someone's overall fitness. And comorbidities, which is really other medical problems, blood pressure, diabetes, heart disease, etc. We think about patients' values and preferences. Are you okay with doing this more intensive 5-week ramp up, this short-term pain for a long-term gain? Or are you saying that is ridiculous, I'm not gonna do that, I just want, give me something quick, I wanna go home, I don't wanna have to deal with all that. We think about that, what your preferences would be. And then, of course, particularly in our publicly funded healthcare system, we have to think about cost and availability. And I have to say, we are so fortunate. So despite us having a publicly funded healthcare system where there's obviously constraints and funding issues, we've actually had most of these novel agents available, often a little bit behind the United States, but not that far, actually. We're quite fortunate that we have access to most of these drugs within our system. So I'm going to go back to our case. This was our 67-year-old gentleman. He had no symptoms initially at diagnosis. It's 3 years later. He's now got symptoms suggesting that he needs treatment. Let's say his prognostic testing showed that he had, there's two main things we look at. He had unmutated IgHV, and by FISH, he had trisomy 12. This puts him in an intermediate risk category, so not the good risk, not deletion 17p, which is the kind of bad risk, but he's in intermediate risk. We heard discussion about doing testing for TP53 mutations. In most centers in Canada, that's not yet available, so for him, we don't have that result. It's coming, though. Most of the major centers are trying to roll out these kinds of panels to test for this. He has some mild high blood pressure. He's otherwise healthy, and he's active, travels frequently since retirement, and in terms of kind of values and preferences, this patient really, his goal is to spend the most time he can with his grandchildren. So here are the possible treatments we could think about. So the ones we've talked about already. Chemoimmunotherapy. In this case, we'd think about bendamustine and rituximab. Usually we don't think about FCR unless somebody's under 65 generally. BTK inhibitors, we have the three main ones, ibrutinib, acalabrutinib, or zanubrutinib. And when we give those, we give them, we say, indefinitely, meaning you start it and you're just on it. Kind of like being on a high blood pressure medication, you just stay on it until either it's causing too many side effects that you need to come off of it, or your disease is starting to grow. And then we have three options that are what we call time-limited or fixed duration treatments, because you only take them for a short period of time. So venetoclax obinutuzumab, or the combination of ibrutinib plus venetoclax, that's a doublet. That's Health Canada approved. It's actually not approved in the United States. And it should be funded, I believe, in the next couple of months in my province. It's kind of making its way through the funding algorithms in the different provinces. And then I put in italics because this one's not yet available, but acalabrutinib plus venetoclax, so that's now using one of the second generation BTK inhibitors. There was some really exciting data that came from our most recent meeting at ASH this year showing that this combination is effective, and I do think this will come. It'll likely take another year or so to be available in Canada. So how do these compare? So I'm going to summarize many clinical trials and years of research here into 2 slides, basically, and really just highlight the key points here. So in general, I'll tell you that there have been clinical trials that have compared various kinds of chemoimmunotherapy with sort of all the newer novel agents. And the winner for most trials has been the novel agents. So BTK inhibitors have been shown to be more effective than chemoimmunotherapy, the combination of venetoclax obinutuzumab, and then these doublets, ibrutinib venetoclax and acalabrutinib venetoclax. The one caveat here is that these differences and kind of the win has been the most marked in patients with the higher risk disease, so particularly those with deletion 17p or unmutated IgHV. In some of these trials, patients with the good risk disease, which is mutated IgHV or deletion 13q, sometimes actually they were equal. So chemoimmunotherapy is still a very reasonable option for those in some of those situations. So just to keep that in mind. So just a summary, clinical trials have consistently shown that these novel agents work better than chemoimmunotherapy. And there's 2 main things we look at. We look at how long does it keep the cancer away. We use this term progression-free survival. And also in some cases, and also we look at how does it make patients live longer or overall survival, which we heard about in the first talk. So what about within all these novel agents? Have they been compared head-to-head? Well, ibrutinib has been compared to the second-generation BTK inhibitors, acalabrutinib and zanubrutinib, and basically the second-generation BTK inhibitors kind of win over ibrutinib, both based on side effect profile, so that there's less side effects. And in some cases, particularly with zanubrutinib, there was one trial that showed maybe it was actually even more efficacious than ibrutinib, and that, we're still kind of learning about that. What about acalabrutinib versus zanubrutinib? This is a question that often comes up in the clinic, and my colleagues are smiling here because really, we don't know. And I put a question mark here, and most likely they're equal. There's been studies that have tried, no clinical trial has compared these two head-to-head, and that's really the gold standard. That's what we need to say if one's better than the other. Instead, people have looked at trials with acalabrutinib, trials with zanubrutinib, tried to do some fancy math and compare them, and sometimes it shows one's better, sometimes it shows the other's better, and it really, I think, all evens out. And I hope my colleagues agree. They have slightly different side effect profiles. Acalabrutinib can cause a bit more headaches. Zanubrutinib can cause some low blood counts. So there's a few things we think about, but often it just comes down to what's available in your province, what your physician is used to giving, what that center gives. Some centers have different preferences. So certainly a discussion to be had, but I don't think we have to agonize about these two. They're both excellent drugs. What about the concept of a time-limited therapy like venetoclax obinutuzumab, which is only for 1 year, versus ongoing treatment with a BTK inhibitor, so indefinite therapy? These trials are ongoing. We don't have answers yet, and it's actually not clear if one option is better than the other. The caveat is with the ongoing treatment, the BTK inhibitors, particularly in patients with the higher risk disease like deletion 17p, it does seem to keep the disease in remission longer. But we don't know if that's really, it might keep the disease away longer, but maybe if someone had the short treatment first, then they had a nice treatment break, then they went on that longer treatment, we don't know that that's any different than the other way around. So yes, especially with deletion 17p, high-risk disease, people tend to choose these more indefinite therapies. We don't have all the answers yet, and some of these trials are ongoing. And then the final thing would be comparing different time-limit approaches. So venetoclax obinutuzumab versus these doublets like a BTK inhibitor, like ibrutinib plus venetoclax, or acalabrutinib plus venetoclax. And there are trials ongoing looking at those. So that's just my summary there. I would say we know from these trials that the second-generation BTK inhibitors are better than ibrutinib as a single agent, that there's no clear difference between acalabrutinib and zanubrutinib, and that it's unclear whether what's better between BTK indefinite monotherapy versus these time-limited options, or the difference between the two different kinds of time-limited options. So how do we think about, what are some pros and cons of these novel treatment strategies? So let's first talk about the indefinite treatment with acalabrutinib or zanubrutinib. These are pills. It's easy to take. The doctor can prescribe them. You're in the office one day, you pick them up, you go home, you start. It's easy. We've talked about this. They may be better for patients with higher risk disease, particularly deletion 17p, where patients have been shown to stay in remissions longer. It's unclear if or when you can stop it. So we now have patients who've been on ibrutinib for years, 8 years, and they're asking, do I need to still be on this? Can I stop it? And we don't really know. There is the concern of development of these resistant mutations, because these are drugs that you just stay on. So it's like being on an antibiotic for a long time. Are you going to develop these mutations eventually? That is usually what leads to somebody progressing on the drugs, but it might take years for that to happen. And then we have the side effects that we already talked about of these drugs. Just a little star here when I say that the BTK inhibitors may be better for high-risk disease. In fact, this has played into some of the treatment algorithms in Canada, where in some provinces you actually might not have access to these drugs if you have what we call good risk disease, so mutated IGHV, and that's in the frontline setting. In the relapse setting, we do have access to these drugs. So what about the time-limited options, the venetoclax obinutuzumab or ibrutinib venetoclax? These might be a bit more intensive, especially at the start, that short-term pain for long-term gain. So there's IV treatment, you have this ramp up if you're using venetoclax. IV is if you're using obinutuzumab. You might have less time in remission for high-risk disease, but as I mentioned, it's not really clear if there's any downside to kind of starting and stopping treatment over time. You develop less resistance mutations, and actually clinical trials have shown that with short treatment, like 1 year, almost no patients develop any resistant mutations at the end of their trial. Actually, none in the trials that have been published so far. And the side effect profile is a little bit different. With obinutuzumab, you get some of those things I talked about, infusion reactions, immunosuppression, decreased vaccine response. You would get the same side effects of the BTK inhibitors, but it's only for a year, so your risk of getting those side effects is shorter. And there are some side effects with venetoclax with the low white blood cell count. Some people do get some diarrhea with it, not that common. So let's go back to our case. So this was our patient, 70 years old, needing treatment. He's intermediate risk. He's fairly healthy. So I have many patients like this in my practice. We always discuss the pros and cons of the various options that might be available. And in this case, and many patients do want time-limited therapy. It means that, yes, it's intensive for the first couple of months, but then it's only 1 year, and then you're done. Can travel, can do your normal activities, hopefully forget maybe you even have the disease for a period of time. So this patient, he went into remission at 15 months, and now he's back to all his usual activities. I just have a couple more slides talking about what happens when patients relapse. So that was all sort of focused on first-line therapy. There's things we think about when someone relapses. Did they, or when they progress, are they on treatment? For example, are you still on a BTK inhibitor and your disease is growing? Did you stop your treatment because your disease was growing? Or did you stop prior treatment because of side effects? Because that kind of plays into what we decide to do at relapse. If you stop because your disease was growing, usually we will switch drug classes. So if you're on a BTK inhibitor, maybe now we'll go to a BCL2 inhibitor combination. But if you had side effects, maybe you had side effects to ibrutinib, you stopped it, and it's 3 years later, your disease is progressing. It's very reasonable to reconsider a different BTK inhibitor. Maybe you won't have the same side effects to that one. Other things we think about, as mentioned in the first lecture, we want to repeat prognostic testing. Have you now developed one of these higher risk features like deletion 17p or TP53 mutation? Hopefully by then we can do it. And then should we check if you've developed resistance to prior treatment? We can check for mutations for resistance, but we're still learning a lot about this. Even if you have one, you know, if it's the only treatment option available, we would probably still try it because it might still work. We're still learning a lot about it. So I don't know that testing for resistance mutations, at least in Canada yet, will affect how we guide treatment, but definitely I think it's coming, and I think in the years to come we'll hear more about that. In general, when we think about treatment at relapse, we usually do think about switching classes. So if someone had a BTK inhibitor, we'll switch to a BCL2 inhibitor kind of combination. Or if you had a time-limited treatment, we could even repeat it or repeat something similar. So patients who get venetoclax obinutuzumab first, when they relapse, could also get venetoclax. We combine it with rituximab at the time of relapse. It's actually given for 2 years instead of 1. And studies have shown that retreatment with venetoclax can still be effective. Or maybe if you started with ibrutinib venetoclax, actually part of our Canadian guidelines say that you could even consider just repeating that same treatment again. So that's beneficial, just another year of treatment, then you're on a break again. Or we think about new classes of drugs, and we're going to hear about that in the next lecture. So there's non-covalent BTK inhibitors, CAR T cell therapy, a whole class of drugs called bispecific antibodies. It's a type of immunotherapy. Clinical trials with new drugs, BTK degraders are a big one that are being talked about a lot now. And stem cell transplant, I'm not going to spend too much time. There might be patients in this room who've had stem cell transplant. We used to use it, not infrequently in CLL, but now with these newer drugs, we're using it less and less. And then this question comes up about sequencing. What we mean by this is what order should we give things in? BTK first, then BCL2, or the other way around? And we really don't know. And it's going to take a long time for the data to show us what the best option is, because if you think about it, patients with CLL are doing so well on treatment. They could have 8 to 10 years remission with a first BTK inhibitor. Then you're going to go on a BCL2 inhibitor, get another 4 to 5 years remission. That's going to take 15 years for us to see how well someone did. So it's going to take a long time, and it's going to take a lot of what we call real world or observational studies, which is where we actually need folks like you to contribute to this research. We want to look at your outcomes. We want to look at a whole, in Canada, how are patients doing when they get treated with these drugs? And there are clinical trials that are now starting to address this question. But for now, we don't have a lot of information, and I don't think we know that one's better than the other, so they're all excellent options to start with. And I'm just going to end with this last slide. And this is meant to be just a really encouraging and optimistic view of what's happening in the world of CLL. Since 1949, you can see here on this chart, we were using chemotherapy, they were using chemotherapy. Then we got into this era of chemoimmunotherapy, which we talked about. Now we're in this era of targeted therapy with all these new targeted drugs, and getting into this concept of combination therapy, time-limited therapies. And the future, we have so many new options coming down the road that it really is an exciting time from a research point of view, and a really optimistic time for patients with CLL. So I'll end there, and happy to take questions.
Yeah, we're good for time. Okay. That was just a fantastic talk, and that is a difficult thing to do, to summarize a complex landscape of treatment in a way that was just so understandable. I mean, thank you for sparing us the trial slides of PFS curves, and that was really, really good. And really, I think while we're waiting for the mics to get around, really, I think what I took away from that also was just the the need for that very person-specific approach to management. This is it's easy to kind of ask the person next to you, what are you getting, or what are you getting, and wonder if you've missed out on the best available treatment. Well, I think this talk really highlighted the fact that there are a number of excellent treatments, and the choices for one over another may be very specific to an individual, and it can be completely reasonable to have more than one approach. So that's great. We're starting questions in the back corner there.
Great.
Yeah, more of a comment. That was one of the best presentations, and I've been here to pretty well all the sessions. So to mirror Graham's comments, very well done. Thank you.
Oh, thank you. That's very kind.
Thank you. Excuse me. I graduated from FCR to ibrutinib to zanubrutinib, and with ibrutinib I was experiencing side effects which were partially managed through blood pressure pills and that sort of thing. But I also requested that I reduce the dose, because when you look at the pill bottles, it's the same dose whether you are 90 pounds or 490 pounds. And so I went from 3 pills a day to 2 pills a day to 1 pill a day, which didn't seem to affect really the efficacy of the drug. Now on zanubrutinib, I'm asking the same question, as whether we need to go that full dose. Thank you.
Yeah, that's a great question. So this concept of dose intensity, we call it, or whether it's okay to reduce the dose. And there have been trials that have tried to look at this, or at least kind of observational studies that have looked at this. And in general, you're absolutely right, it is felt that dose reductions are helpful or will not impact efficacy. And may help side effects. It doesn't always, so not everybody who reduces the dose has improvement in their side effects. And there might be some data, there are some cases where I have actually, someone's been on a lower dose for some reason, and maybe things are starting to progress, and I've increased the dose, and it has gotten the disease back under control. So there probably is some component of dose that matters. However, especially if somebody's been on for a period of time, so usually in the first year or two, and I'll ask my colleagues, I try not to change the dose too much, but after that, if someone's stable, often they have no CLL that's, maybe if we did a marrow, we would see it, but if in their blood and their lymph nodes are all gone, I feel quite comfortable reducing the dose at that point. And even sometimes we stop if someone's really got side effects that are too frustrating, or sometimes people are just tired of being on it and say, hey, I really want to stop. This is where I was talking about where we don't have a lot of that information, and it is very reasonable to consider in those scenarios. Yeah, and the good thing for zanubrutinib, actually, it's soon. Maybe you won't want to reduce the dose because soon the pills are going to change, and you're going to go from taking 4 pills to, I believe, only 2 pills a day, and that's coming soon. So that is also comes into it. How many pills are you taking? Is it once a day, twice a day? A lot of these things also factor in.
Over here.
Yeah,
Hello.
perfect
Oh,
in the
yeah.
back here.
I was wondering, in one of your sessions, slides, or where you were talking about chemoimmunotherapy.
Yep.
And you mentioned a certain combination, I think it was rituximab and obinutuzumab, whatever. Yes, that they kill all B cells. And I'm wondering, in the targeted combinations, do they still kill all B cells?
Yeah, that's a great question. So they do. You're right. So targeted therapy, I would say obinutuzumab and rituximab, those monoclonal antibodies, are also targeted therapy. They're targeting. It's not killing all rapidly dividing cells in the body, but you're right. It's not only killing cancer cells. It's killing B cells. Now, some of these proteins we talked about in the CLL cells are more active, and so it's maybe killing them a bit more than the normal B cells, but it is still killing normal B cells.
So
Yeah.
in that case, I'm concerned mostly about the memory B cells. I don't think they're rapidly dividing. So are they spared from being killed, or are they killed as well?
That's a really good question. They are killed, although we do know, so memory B cells are kind of, sort of what it sounds like, B cells that keep a memory of often other bacteria and viruses that you've been exposed to and vaccines, so that when you do get those infections, your immune system's ready to go to attack them and kill that bacteria or virus. So even though we're killing B cells, it's not that people have zero. If people have been vaccinated before, they still will be able to mount a response to vaccines. And still, as we talked about, we can check titers. They still have antibodies evident in their blood. So it's not killing all the memory B cells. And that, I don't know if you have more to add to that.
Hi,
We've got a
over here.
question
Yeah.
Over here.
I've just recently been diagnosed within the last month.
Oh, wow.
So I just had a quick question. God bless all of you who have been going through hell. That's all I can say. It's very encouraging to see how many people are surviving this, this condition, disease, whatever way you want to put it. I had a question about the RSV vaccine. I keep up with every vaccine possible. God knows how many COVID shots we've had throughout the years, and,
Yeah.
and our annual pneumonia shots and anything else, and flu. I've never had an RSV. Would it be recommended for me to request that when I
Good
go for
question.
a physical?
So this will likely depend on your province as well, and in terms of what's available. The RSV vaccine is actually approved for adults over 65 or 65 and older. And I've had discussions with our infectious disease colleagues asking, in patients under 65 with CLL, do you think we should still recommend the RSV vaccine? And their general comments have been, unless there's a real reason that they're very immunosuppressed, maybe multiple prior treatments, stem cell transplant, probably not. It is only a one-time vaccine, and so you're not going to get boosters. So if you get it when you're very younger, not sure how effective it will be in the future. That might change in the future, and I'd love to hear what my colleagues say about this as well, because I do think we're still learning about RSV. It is recommended by the NACI, which is the Canadian National Immunization Group, for patients over 65. However, it's not funded. in most provinces. So a little bit like shingles is also not always funded. I do find people can get it often if they have extended health care, they can get it covered through that. So it's, I think it's beneficial. If you're over 65, I do recommend it if people can consider it, but understand that it's not actually publicly funded.
Thank you. And the second question I had, I'm also a survivor of thyroid cancer.
Yeah.
So I've been through all the different levels between radiation. I had a special radiation done. I've had the chemo pills. Mm-hmm. Is there a difference between, like talked about the dosage between a chemo pill and infusion?
It depends on the type of chemotherapy. So usually we know what the equivalent dose is. If you give it IV, it's given at a certain dose. You give it orally, it's given at a different dose, but we know what the equivalent is. And not all chemo can be given as a pill.
Oh, that's what I wanted to know. So it depends on what type of treatment that would be that would come under.
Exactly.
Okay, thank you.
Yeah.
We'll have time for one more, and then we'll move on.
I was going to try to sneak two in, but I'll just stick with one.
Yeah.
You've talked about the importance of person-specific care and treatment,
Yep.
and also the fact that hematologists and institutions have a way that they do things. So I'm concerned. I had FCR 7 years ago. I'll get emotional. I'm sorry.
Yeah.
And I was 39 when I was diagnosed, and I've relapsed and have had a new mutation. I'm sorry.
No, thanks
So
for
I'm just
sharing.
worried that, what if we don't get it right? Like, what if she's not looking at my specific risk factors? We're
Yeah.
in a province that is burdened by a healthcare crisis.
Yeah.
So I just feel like people's eyes aren't on the balls because they have too many patients. My clinicians are aging out.
Yeah. Yeah.
So at what point do I advocate for myself for what I need, or trust that somebody
Yeah.
is as knowledgeable as you?
Yeah. Well, thank you. And also thank you for sharing. I can appreciate that's really hard. And I think, and it's not all physicians are able to devote. I feel very fortunate that I'm in a situation where I can devote so much to one very specific area of medicine. So of course I am able to know all the trials and all the things. I think always we need patients to advocate. I think the fact that you're here, you're learning, ask those questions, bring it up. Bring the information that you have. Ask about your prognostic markers. Not at all. No. Physicians no. We love it when people come in when they know and they're interested and they're asking questions. Ask to get your reports. Ask to actually have it in print, what you have, what your prognostic markers show. And if they say that they can't test it, there are differences in provinces in Canada, in centers. If they say they can't test it, ask, is there any way, and it's even okay to ask for a second opinion, and it happens all the time in medicine. We're not offended, we understand. And so, yeah, I encourage you to bring all this information that you're learning forward and talk about it with your doctor.
Yeah, great advice. And I think maybe the other perspective to recognize is that there are excellent, hematologists and physicians that may not only be focused on one specific area, and there's a lot of sharing and knowledge that happens among, kind of providers in our country and in our countries. And so, it is, I think, there's a need for you to be comfortable with who's looking after you and to ask those questions, but at the same time, it's not necessarily the case that if you're not seeing Dr. Banerjee or Dr. Gerrie, that you're not getting good care. And if somebody takes offense by asking questions about a second opinion or wanting information, that's probably a pretty good clue that that's not the right person for you. And you need to think about, kind of, are you being looked after by somebody that you're comfortable, you can have those discussions and, take the time to get the information that you need to make these extremely important decisions that affect your life, right? So think about that. I think thank you so much, Dr. Gerrie. That was